We will be moving on now to lower extremity venous duplex. And this one is probably the most frequent exam that we do as a vascular technologist. So you'll want to get really familiar and really comfortable with this exam as you'll be doing multiple of these in a typical workday. As always, make sure you take a lot of notes because I'll be adding a lot of tidbits and things that are not included on the PowerPoint slides themselves. First, we're going to talk about patient prep and positioning. For this exam, there is no patient prep. The patient doesn't need to do anything prior to coming for their exam. Once they are in the exam room, the patient will need to remove their pants and change into a gown, or I typically will just have the patient take off their pants and then lay down on the bed on their back and cover up with a sheet. I find that the gown tends to just kind of get in the way, so it's easier just to have them remove their pants. But the patient will be laying on their back in the supine position with their leg bent, kind of like a frog leg. So the same way that we scanned lower extremity arterial, we're going to scan lower extremity venous. We use a linear probe for this. And the other different thing or kind of important thing is positioning of the patient and the bed itself. So when we do lower extremity venous, we will often put the patient in what's called a reverse Trendelenburg position. So you can see this here. It's where the patient's feet are actually lower than their head. And you can do this by, pumping up the bed and then just using the foot pedal to tip the feet instead of lowering the whole bed or the head. You can use the one towards the feet to just tip that section. So what this does, it allows for pooling of the blood within the veins, and it makes them a little bit bigger and easier for us to see. So especially those calf veins that are going to be small and a little bit of a struggle, the reverse Trendelenburg can really help with that. So as far as patient history, we are going to get into a whole new type of questions and thought process for questions. With anything arterial prior, we always had the, high blood pressure, high cholesterol, diabetes, that sort of thing. Not so much relevant with venous disease. So kind of throw those out the window. Those really, it doesn't hurt if you ask them, but they're not really relevant when it comes to venous disease. So we're going to flip the switch here a little bit. And the first thing, typically you'll ask your patient, the main two things that they may have is pain and swelling. Okay, so pain and swelling. You want to ask your patient if they have any pain and swelling in their legs, and if so, for how long has that been going on? We want to know the duration, especially with this, because with blood clots, which is what we'll be looking for, you can have a blood clot that's acute, meaning it occurred, in the last day or two, maybe within the last week, or you can have something that's chronic, which means, it's been around for a long time. Maybe they've had a prior diagnosis of a blood clot, and that wouldn't be as concerning. So if this pain and swelling has been there for 3 years, then we're not thinking that this is probably an acute process or an acute problem. But if they're saying, I had sudden onset swelling, a day ago, and it hasn't gotten any better, then that's maybe when we would be concerned. We also want to know if they have any redness or warmth to their leg. Blood clots can cause those issues as well. And again, we kind of want to know how long. Another question is injury. We want to know if they've had any injuries to their legs. Did they get kicked? Did they fall? Did they get in a car accident? Because sometimes things like that can cause blood clots as well. We want to know if they've ever had a history of deep vein thrombosis. So if you see that DVT or deep vein thrombosis, that's a super fancy word for blood clots. History of blood clotting disorder. Some people can have, some gene mutations or different things like that that actually causes their blood to be thicker. So we would want to know if they have any diagnosis with that. And sometimes patients don't get diagnosed until after they've had a blood clot. So they come, they have leg swelling pain, we diagnose them with this blood clot, and if they begin to get them frequently, their physician may order some sort of blood test to determine if they have a blood clotting disorder. Surgery, we want to know if they've had any recent surgery or to the blood vessels themselves. So this is where it's kind of important if a patient has abdominal surgery, let's say. They're going to be laying around potentially, resting a little bit more, not getting up and walking, which could cause, their blood to get thicker and potentially a blood clot. So any type of surgery is actually relevant when a patient comes in for this type of study. And then, like I said, specifically, you want to know if they've had any surgery on their blood vessels in their legs. If they've had, a vein stripping or something like that, we don't want to be looking for a vein that's not there. We want to know if they're on any blood thinners for any reason, whether they've had a blood clot before, if they have a blood clotting disorder, whatever it may be. That's always a good thing to document if they take any blood thinners. And then if it's a young female, another important question is if they are taking oral contraceptives, because those they do have a link to causing blood clots. I'm not going to ask a male that question. Obviously, I'm not going to ask a 70-year-old woman that question. But if it's a young female, I will ask about oral contraceptive use. And then, as always, don't forget to review the order, check for any previous, especially lower extremity venous. If they've had a blood clot before, we want to know where, because sometimes those never go away and they can turn into more of what's that chronic process that I was talking about. So you want to make sure that you know if they've had any prior documentation of a blood clot. Always double identify your patient, and of course, always wash your hands. So as you can see, these questions and thought process is quite different than anything arterial that we have done. So just make sure you're studying these and practicing asking your patient because, it's a little bit different than what we've done before. Okay, so I wanted to talk a little bit about Virchow's triad. So this is super important. Make sure you star this, highlight it. This is registry information. So what Virchow's triad is it defines the risk factors for thrombosis. So not history questions or symptoms or things like that. These are strictly risk factors. What type of things are going to cause a patient to be at a higher risk for a blood clot or a thrombosis? Okay, so I added these two charts over here. I really like this top one because it outlines each of the three, and then the bottom one gives some additional examples as well. So I wanted to put both of those on there. But the three pieces to Virchow's triad, first one is hypercoagulability. So hyper means increased, coagulability means clotting. So anything that's going to cause that blood to be thicker. Okay, and there's different types of things, like it lists cancer, thrombophilia, inflammatory diseases, down here major surgeries, pregnancy, there's all sort of things. You guys can look through those different risk factors, but anything that's going to cause the blood to potentially be thicker, so hypercoagulability of the blood. Next one, vessel wall injury. Vessel wall injury. So this could be surgery to the vessel, any type of chemical irritation or inflammation to the vessel itself. And there's some additional ones down here, cellulitis, venipuncture. So let's say you have a blood draw, and this would, typically be in the arm, but that can cause a blood clot because it, injures the vessel wall and causes irritation. Next one is stasis of blood, okay? So anything that's going to cause the blood to maybe not be moving or, getting around quicker than it should, okay? So stasis of blood. Immobility, okay? So somebody who is bedridden, somebody who just had surgery, varicose veins, or venous obstruction. And it pretty much lists some of the same things down there at the bottom. So these are our three components of Virchow's triad. Star these, know those three components. And if you're ever asked a question about, what would be a risk factor? Okay, what would be a risk factor for a blood clot? Anything that falls under these three categories, hypercoagulability, vessel wall injury, or stasis of blood. So that's where your mind should go. Anything that falls under those three categories would fit as a risk factor, for a DVT or a blood clot. And then I just listed a few over on the side. Obesity, that can cause, some pressure where there's stasis of blood. The blood is not moving as quickly, or maybe these patients just are not as active as well. Oral contraceptive use, I talked about that. That causes hypercoagulability of blood. Age, again, maybe they're just not as active and they're not moving around, so we have some of that stasis of blood. And then cancer or chemo can also cause hypercoagulability. So make sure to review these charts, even look on Google for some different other ideas, but you will definitely want to know Virchow's triad, the 3 components, and then be able to actually list some different things that is, puts a patient at a higher risk for a blood clot. I wanted to talk just a little bit about the sonographic appearance of venous flow and veins themselves as opposed to the arteries. So the lower extremity veins will appear as anechoic tubular structures that course from inferior to superior. So I want you to think about that for a second. Arteries are taking blood from the heart down to the feet, okay? Veins are bringing blood back to the heart. So veins actually will course from inferior to superior. They form, distally and come back towards the heart, okay? Arteries will run the same course as the veins. So all of the places that you looked for the arteries before, you're going to see the veins right there in that same place, okay? They run parallel, they run together. However, one good way to tell the veins from the arteries is that the veins will be compressible. So we've talked about this a little bit already, but when you push, when you add some pressure, veins will be compressible. They have thinner walls that allow them to compress. So that's one, easy way to tell the difference between an artery and a vein. Color flow will be seen within the veins. Typically it's blue, okay? Not 100% always all the time. There are, some different variables there. But on a normal vein, a normal basis, color flow within the veins will be blue, okay? Direction of flow will be from right to left on the screen. So again, think about our screen orientation: anterior, posterior, superior, inferior. So remember, blood flow is coming from inferior and moving to superior. So our blood flow is going to be from right to left on the screen. And pulse wave Doppler will show flow that should be below the baseline. Okay, so you can see that down here. The flow is going to be below the baseline because, again, it's moving in the opposite direction. Arterial flow was above the baseline, okay, because it was moving left to right. This venous flow is moving right to left, so it's in the opposite direction. You're going to see that blood flow below the baseline. So let's get into scanning of the lower extremity veins. We will take images and obtain them at each level, starting in the groin and all the way down to the ankle. We'll get into the actual protocol on the next slide, but you're going to obtain images at each level, the first one being in grayscale, and we are actually going to scan in transverse with a dual screen. So you can see that up here in the left top corner. It's a dual screen image. This is of the calf veins. So we haven't taken a lot of images in transverse. I always teach you guys to start in transverse with scanning, but we haven't actually scanned a lot or imaged a lot in transverse. We haven't used dual screen yet, so this is going to be something new that you guys get to incorporate as well. So at each level, we are going to take a grayscale transverse image to demonstrate compressibility. So you can see that we take one image, and this is flipped. Normally we put, the non-compressible image on this side and then do a compression image on the right side. We're going to label our vessels, and this is really probably the most important image that we take is the compression image. Demonstrating compression pretty much rules out a blood clot within the vein. We also take color images at each level, and then depending on the location, we will also do a Doppler with an augmentation. So this is something completely new as well. Augmentation, you can see, is seen here on this image. It's actually going to be an increase of blood flow caused by an augmentation. So you're actually going to take and squeeze the patient's leg distal to the Doppler, and it causes this kind of whoosh or increase of blood flow that travels through the vein. And this will be easier to see when we can show you in the lab what this looks like, but just know you will be doing Doppler and augmentations at different locations. You'll document any areas of non-compressibility or absent or decreased flow. This would likely signal a blood clot or a DVT, so you would want to make sure to document that. So here is the protocol that we follow as far as a lower extremity venous. Now, some sites are going to be a little bit different. I've seen some that don't really look at the calf veins much, some that do more in the calf veins than other. But this is, kind of a typical protocol and something to get you used to what a lower extremity venous exam looks like. So first of all, we're going to start up in the common femoral. Okay, common femoral is pretty short. It's going to be there at the groin crease. You can see here the saphenofemoral junction. Okay, so this is where the great saphenous vein, they have some of it cut out, but the great saphenous vein would travel along the inside of the leg here. You'll see this as it comes up. This is where that saphenous vein joins into the common femoral vein. And we talked about that a little bit when we were doing arterial. For imaging of the common femoral vein, you want to be above the saphenofemoral junction, okay? Above that, our next image is often a compression image at the saphenofemoral junction where that joins in with the common femoral vein, okay? So you'll kind of take two images in that area, one above, one right at the common femoral, and then we are going to do one right at the deep femoral and femoral vein split, okay, really proximal there. So 3 images right in this area. These are bigger vessels, they're important. We want to make sure there is no blood clots or, DVTs in that area. Then we follow down the femoral vein and do like a mid-femoral imaging, distal femoral imaging, and then into the popliteal. Going to take the same approach that you did with arterial and come posterior from behind the knee. Then we move into the posterior tibial veins and perineal veins, okay? So you're going to image those just like you would with the arteries. Now, the important thing to remember is posterior tibial veins and perineal veins. There are 2 of each, okay? So once we get to the calf, there are 2 veins to 1 artery, okay? So you have to rule out DVT in both. Okay, you could have a blood clot in one of those vessels and not the other. So it's very important that you're seeing all of those vessels when you get to the calf. Now, we don't typically image the anterior tibial veins. A few places may include that in their protocol, but most places have stopped if they ever did visualize the anterior tibial veins. It's not common to get a DVT in the anterior tibial veins. So, that's likely omitted from most protocols. We also imaged the great saphenous vein, which it's cut away from this image, but it would actually run from the whole entire length of the leg. So it is the longest vein in the body, the great saphenous vein, and it runs from the ankle all the way up to the groin. Okay. Now, the great saphenous vein is what's considered a superficial vein. Superficial vein, meaning it doesn't have an artery. Okay, it doesn't have an artery that goes with it, and it's much more superficial. It lies within the fascia as opposed to down, near the muscles. Okay, so great saphenous vein is superficial. Now, two quick things I want to talk about the femoral vein. Okay, it is very, very common to have duplicated femoral veins. Okay, so if you are scanning your patient or a classmate here in the lab, don't be alarmed if you see 2 femoral veins. Super common. It's a normal variant. Okay. The other thing I want to talk about the femoral vein is the name. Okay. If you remember when we did arteries, it was the superficial femoral artery, right? And then the deep femoral or the profunda. Okay. When we're doing veins, it is strictly just the femoral vein. Okay, it is not the superficial femoral vein. I will mark you wrong if you write superficial femoral vein. It's very important not to include that for the following reasons. Because we have deep veins and superficial veins within the legs, okay? Technically, the superficial femoral vein, when they called it that, is a deep vein, but it brings on a lot of confusion, okay? it brings on a lot of confusion, and there were numerous patients that had deep vein thrombosis, which is a very serious condition, in their superficial femoral vein, and the physicians were sending them home with these blood clots because they thought it was just a superficial vein. Okay. Superficial veins do not have a direct pathway back to the heart and lungs. It's not going to cause a PE or a blood clot in the lungs. It's not as serious, but a blood clot in the deep veins is very serious. And when these physicians were hearing the word superficial, they were not treating it. They were sending these patients home without treatment, thinking it was just a blood clot in the superficial system. When here it's in the femoral vein, which is a direct pathway. I mean, it's a big vessel. So if you have a clot coming from the femoral vein, that could be really, really bad for the patient. So I would say maybe 10 years ago, they changed this and strictly are calling it the femoral vein now, not the superficial femoral vein. So make sure you make note of that. Just FV as the abbreviation. And then for deep femoral, you can use deep femoral or profunda femoral or profunda femoris as, the name for that. So just make sure that you're familiar with all of these vessels, the names, the locations. It should come pretty normal. Most of these follow exactly where the arteries were. So you guys should be pretty familiar with that from arterial scanning. And now we just have to scan the veins. Just wanted to throw in some scanning tips for lower extremity venous Dopplers. Always make sure to try different approaches. I know that we still sometimes get stuck on, I found the vessel, I found what I'm looking for, I'm not moving, but really just a little bit of a different slide or an angle or even positioning of your patient can potentially, help get a crisper, more clear image and allow you to see the vessels better. So don't be afraid to try different approaches. As always, start in transverse. It's the easiest way to find your vessels and know your landmarks to find the vein. Sometimes the best landmark for venous scanning is the arteries. You know where to find those. They're not going to compress, so that's an easy, kind of landmark to use. Compress and watch for movement. This is another nice one if you're struggling to find the vessels. Try a little bit of pressure and then let up. A little bit of pressure and let up. You should see the veins collapsing and opening, collapsing and opening. So you can always compress and watch for movement to know that you found the vein. Depending on the depth of the vessel, you may need more or less pressure. Just keep in mind, if you push too hard, you can actually collapse the vein and then it's missing and you can't find it. So I've seen this before where students struggle because, you're used to us saying, push harder, you got to push, you got to add pressure. But now that we're scanning veins, too much pressure can actually compress the vessels. So depending on where you're at, I mean, if you're in the groin, the vessel is going to be very superficial, so you're not going to need a lot of pressure. But if you're in the mid to distal thigh, you're going to need more pressure. So it just depends on where, you're scanning. If you're struggling to get flow or color within the vessel, you can always try a distal augmentation to help fill your vessel with color when you're trying to get that color image or your Doppler images, or just to find them sometimes. So if you're struggling and you think you found it, but you want to verify, squeeze the patient's calf or distal to wherever your probe is to see if you can get that vessel to fill with color. It's perpendicular is always the best for grayscale imaging, so make sure you keep your probe at 90 degrees from your vessel. And then obviously, like we've talked about before, a slight angle is always best for color imaging. So if you hit something at 90 degrees, remember that you will not get color. So you always want to make sure that you have some angle for the best color imaging. And then if you're struggling with those calf veins, you can always decrease your color scale. For the calf vessels, you can always use that distal augmentation. There's a lot of different things that we can, try to work on to get that color flow or to, better visualize those calf vessels. I think the biggest thing when scanning not only lower extremities, but any study really is just don't get stuck in a rut and don't be afraid to pick up your probe and move and try something different. There may be a better approach window, machine setting. There may be something different that you can try to get a better image. I want to talk about normal venous characteristics. This is a lot different really than arterial flow and arterial scanning. If you remember from the arteries, they are pulsatile. You put the Doppler down, you're always going to get blood flow. Veins are not always like that. It's a little bit trickier to scan, in my opinion, as opposed to the arteries. So as far as the vessel, like we've talked about, the veins will collapse, okay? So they are compressible and they will demonstrate complete coaptation, okay? So if you don't know what coaptation means, it just means compressibility. The walls will collapse upon themselves, and if you push hard enough, you actually will not, see that vessel anymore. So that is a normal venous characteristic, compressibility, and it is probably, like I said, the most important one. Okay, so if you are struggling at all, but you can demonstrate, compressibility of the vessel, this patient is probably not have a DVT. Okay, the vessel should be patent, meaning it's open, it's filled with flow, it's widely open. Those are two, characteristics of the vessels themselves. Now, when we Doppler, some different waveform characteristics. Again, you need to know these, star these. These are super important. But the first one is phasic, okay, phasic. And that means that the blood flow goes in and out with breathing, okay, in and out with breathing. And you can kind of see up here in this image, I tried to show it here. This is phasic blood flow, okay? It goes in and out, in and out. It is not pulsatile. It is not readily available like it is on arterial flow. Okay, you don't put the probe down and it's just there. This is in and out and in and out, and it will change with the patient's breathing. So you actually have an increase of blood flow on expiration. So as the patient breathes out, okay, you get this increase of blood flow, and as they take a breath in, it decreases. Okay, so it's going to decrease with inspiration. So it's phasic, in and out with blood flow. I'm sorry, with breathing, in and out with breathing. Spontaneous. So spontaneous means that it's readily available on Doppler without augmentation, okay? So this type of flow right here would be spontaneous. There is no augmentation to get that flow to show up on the Doppler. You put the probe down and it's within that vessel. Now, this is going to be more common higher up, the femoral veins, the popliteal. Once you get into like the calf veins, those are not typically spontaneous, okay? And that's normal. That's normal. They're smaller. Once you get up higher, those are more spontaneous. And the last one is augmentation. Okay, so we've talked a little bit about this already, but this down here is an augmentation. So what this is a manual compression that increases the venous signal. So you can see there's some spontaneous phasic flow here, okay, within this vessel. But with a distal augmentation, okay, so if I'm scanning like on the common femoral up in the groin, I'm going to maybe squeeze on the distal thigh, and you'll actually get this augmentation response here. And it's okay if it comes above the baseline. It's going to be this increase of the venous signal, so it's going to be exaggerated, okay? So it may wrap around the baseline. That's okay. This is normal. Okay, when we augment distally, we want to see this increase of the venous signal. What that proves is that from the point where my probe is to where I squeeze, there is nothing blocking in between there. Okay, if I squeeze distally and push that blood flow up, I should get this exaggerated response of the venous signal. Okay, so hopefully that makes sense. It'll be easier, I think, when we can show in lab and scan these, and you can see the different effects that it has with breathing and augmentation. But these things are, the normal characteristics of venous flow. So it's not like arteries. We're not going to describe these as triphasic or biphasic. They don't have any of that. They're phasic, meaning with flow. It's spontaneous or it's not spontaneous. And does it augment or does it not augment? Does it compress? Okay, those are the things that you're going to report on. There are different characteristics with the venous flow that could be considered abnormal. We won't get into that a whole lot, but just know if you have what's called a continuous waveform where there's no phasic flow and it just flows straight across constantly, okay, that would be considered continuous flow. So that could be abnormal. If you have pulsatile flow, okay, where it almost looks like arterial flow, but it's below the baseline and it's pulsatile, that could be considered abnormal as well. It obviously depends on the patient, where you're scanning, and some other different factors, but just know those could be abnormal venous characteristics. So here is a little bit more about deep vein thrombosis or DVT. So like I said before, this is what we are looking for. This is what we are trying to rule out on a patient, and why we do all of the images and Dopplers and augments and things that we do. It's to check for a DVT. So at the beginning, I talked a little bit in the history section about acute versus chronic, blood clots, and I wanted to detail what this may look like on ultrasound. It is important to make sure that you are differentiating between the two, because acute DVT is a serious treatable condition. Chronic DVT is not as serious, and typically the patient is not being treated for this. A lot of times you will get these chronic DVTs from a prior acute DVT. Okay, so you just don't get a chronic DVT. You first have an acute DVT, which then turns into a chronic DVT, or one that has been there for a long time. So sometimes blood clots never go away and they just turn into these chronic. I've scanned other patients who had an acute DVT, and I scanned them 6 months later, and I would have never known they had a DVT had I not, seen the prior imaging. So it really just depends on the patient, likely how soon it's caught, and what type of medication, is used to treat this. But when you're scanning and come across, a vessel that maybe doesn't compress, you're going to start investigating. So with an acute DVT, the vessel itself will be distended. So it'll be big, okay? It'll be a lot larger than it normally is, and it'll look dilated. The acute DVT will also be non or partially compressible. You may be able to compress it just a little bit, especially if it's a really fresh blood clot. So you can kind of see over here, this is more of an acute DVT. Here's normal artery vein. You compress on this side, artery vein collapses. And then here we have our artery and our vein. The vein looks bigger here. Do you see the difference between this and this? And then when we push, it compresses a little bit, but we still have the vein here. Okay, so it's either non or partially compressible. It has echoes within it, okay? So we know that normally a blood vessel should be anechoic, but if it's got a blood clot in it, it's going to have some echoes. And with an acute DVT, they are usually homogeneous, okay? We call it very fresh looking. There's going to be incomplete adherence to the wall and a possible tail. So sometimes these blood clots can not hook to the wall, which can be really dangerous for the patient. These blood clots can break off, but that can be very common of an acute DVT. So you want to see if it's adhered to the wall. And then with this, there'll be typically no color flow or maybe just partial color flow. Okay, so that's very common of an acute DVT, distended, it's non-compressible, no flow, or maybe just a little bit of flow. Okay, then in a chronic DVT, chronic DVT, it's going to be a little bit different than that. Okay, so typically instead of the vein being distended, it's going to be small. Okay, so vein looks very small, and then it's somewhat compressible. Okay, it's somewhat compressible. You've got a little bit of vessel left there, but it can be incompressible or very rigid. Okay, it can be partially compressible even. It can take on a few different characteristics. With this though, the echoes within are going to be very heterogeneous and very bright. Okay, you're going to see them. It's going to be very echogenic. These clots will be attached to the wall. Okay, they're old, they're stuck there, they are not going anywhere, so they're going to be attached to the wall. With this, you may have partial flow or recanalization. So you can kind of see in here, you've got some partial flow coming through here, and you can see some clot there still in the center. Okay, so that's what we mean by partial flow or recanalization, is that the vessel begins to have some flow going back through, but it may be diminished. Okay, it's not going to be as good as the vessel was. The other thing that kind of clues you into something being a chronic DVT is the presence of collaterals. So our body, I talked to you guys about this with I-75 versus the back roads. We have the same thing with veins, okay? So we have all these teeny tiny little veins and branches and things. If I-75 gets blocked, okay, it's going to find another pathway. So if there are these presence of collaterals and these other pathways, that is not something that's going to happen in 1 or 2 days. That's something that's going to happen over time, where these collaterals that used to be really tiny small vessels will begin to get larger and actually take over for the vein that had the thrombus. Okay, so if you see those collaterals, you can almost guarantee that that's a chronic condition, because that is something that takes place over time. That is not going to happen right away. So at this point, I feel like it is going to be hard for you guys to maybe 100% understand acute versus chronic DVT. Honestly, until you get to clinic and you really see the difference between these two, it'll make a little more sense. So once you get to clinic, you'll be able to see that, and I think that it'll help you with that. It's a little more difficult just looking at pictures, so don't stress about this. Just kind of know that there is a acute versus chronic, and then, the characteristics of each. There are complications from deep vein thrombosis that are very important and very serious, with pulmonary embolism, or a PE, being the number one acute reason that, us doing our exam is so important. What can happen is these blood clots in the legs can actually break off and travel, up through the heart, through the lungs, and actually cause a pulmonary embolism and a blood clot in the lungs. So these can be very, very serious. Patients will often present with shortness of breath, chest pain. There's even, people that have collapsed and died instantly from these massive blood clots, breaking off and traveling to the lungs. So it's a very serious condition for these PEs. That is one of the reasons why our exam can be considered stat or urgent, because if this patient has a blood clot, they need to get them on bed rest, not moving, started on blood thinners to prevent a PE. Interestingly enough, approximately 90% of PEs are caused by lower extremity DVTs. So they're coming from the legs, which makes, our job super important. That would be like an acute condition, or a reason, for, or a complication of a DVT would be more acute, would be a PE. Then we also have something called post-thrombotic syndrome. And that picture down there on the right looks kind of yucky, but this is what can happen, from DVTs if it's severe enough. Patients can actually get what's called venous insufficiency, where the blood begins to pool down in the lower part of the leg. It doesn't get back up, to the heart where it's supposed to. Veins have valves within them, okay? And we'll talk about this more when we do venous insufficiency specifically. But veins have valves which push the blood back up to the heart. It's going against gravity, so it needs something, okay? Over time, or with a blood clot, these valves can become weak, and instead of the blood pushing up to the heart, it just starts to pool down in the leg, okay? And this can cause all types of things, such as chronic leg swelling and leg pain. It can also cause skin discoloration, as you can see here, and skin sores and ulcerations. So not pretty, okay? And I wouldn't say this happens just because you've had one blood clot, but maybe, a lot over time, or other factors as well. But this would be more of a chronic situation. So this isn't going to happen overnight. This is going to be after years of venous insufficiency that could have been caused by a deep vein thrombosis. Here are some incidental findings that you may come across when doing a lower extremity venous scan. Some of these are arterial, some of those are venous, and some are non-vascular. So the first one is atherosclerotic obstructive disease. So that's what we were checking for when we were doing arteries. You may incidentally see some plaque and some stenosis in, an artery when you're scanning the veins. They run right next to each other. If you see something like that, you want to document it. You're not going to ignore that, even though that's not specifically what was ordered or what you're scanning. You always want to document, other pathology if you see it when you're scanning in that area. And then you may see an acute arterial occlusion as well, where an artery is completely blocked. A pseudoaneurysm, we talked a little bit about that last semester. So a pseudoaneurysm is typically following a heart cath or something of that nature. It's where they actually go in and puncture through usually it's the common femoral artery to run a catheter up to the heart. But when they pull that out, sometimes there's leakage and blood flow can actually escape and create this pseudoaneurysm outside of the vessel. Okay, so we did talk about that a little bit last semester, but that may be something incidental, usually seen up in the groin in the common femoral area. You may come across an aneurysm in the artery, whether it's the common femoral artery or the pop. You can really get aneurysms anywhere, but I would say those are the two most common areas in the lower extremity. We just talked a little bit about venous insufficiency. You may come across this. We will do a whole module on insufficiencies and scanning insufficiencies, so we'll talk more about that and what that looks like on ultrasound when we get there. Baker's cyst. So this is actually a cyst in the popliteal space. So when you go back behind the knee and you're looking at the popliteal vein, oftentimes you will see a Baker's cyst, which is a fluid collection, typically from the knee joint, and it's going to be very towards the top of the screen, very superficial on your screen. Okay, so you're going to see that at the top. If you see that, you want to document it by measuring it, putting color on it, that sort of thing. Those can be confused with a popliteal aneurysm, so it's very important to put color on it to make sure that it is just a cyst with fluid and not an artery with blood flow. You may also see enlarged lymph nodes. Oftentimes these are seen in the groin, very common, especially if the patient comes in with any sort of infection or cellulitis. They get swelling in their legs, so a lot of times we're scanning people with cellulitis to also rule out a blood clot, and they've got these enlarged lymph nodes. Now, we know lymph nodes are going to become enlarged if there's any sort of infectious or inflammatory process. So if you see enlarged lymph nodes, I always like to document those. I just measure and put color on them, and make sure you note those, because that could be, just a key that this patient just has cellulitis and they've got some inflammation because we see these lymph nodes. It's not truly a blood clot. And then a hematoma, this is like a bruising underneath the skin, and this is often a clinical diagnosis as well. So let's say the patient fell off a ladder and they have leg swelling, and you scan them and you see this cystic structure, in the exam. Likely a hematoma just because of the clinical diagnosis. So they fell, they hurt themselves, there's some bruising and some bleeding under the skin, so you could, almost diagnose it that way. Now, key thing here, we are not diagnosing it all, okay? So this is where the patient's clinical history is going to come in. You're going to say this patient fell off a ladder. This is what I see. The doctor, hopefully it'll lead them to that conclusion that this is a hematoma versus something else, okay? So remember, we're not really diagnosing, but we use our clinical skills, patient history to kind of piece it all together. So again, this is just a short list of incidental findings that you may come across. There may be other things, but the key thing is you kind of know what's normal and you know what's abnormal. If you see something that's not normal and doesn't look right, it's always better just to document it. Just document it. Maybe it's nothing, but maybe it's something serious, and you could really make a difference. So in my opinion, I would rather over document than not document at all. I want to talk briefly about a D-dimer. This is a blood draw, okay, so it's a test that a patient can get. This would be prior to coming to you, that can rule out the presence of thrombus, okay? So the patient goes and gets their blood drawn, they run this D-dimer test, and then it comes back positive or negative, okay? If it comes back negative, it has ruled out the presence of thrombus in that patient's body, okay? If it comes back positive, that just means that further testing is required. It cannot actually confirm that there is a blood clot somewhere because there's a lot of false positives that we're going to get into. It cannot actually confirm, but further testing is required. Okay, so if it's negative, it's negative. But if it's positive, then that means there may be, some blood clotting going on in that patient's body, and we need to test further. So typically, we're the first start with lower extremity venous. And then if we don't see anything, they may chalk it up to a false positive, or they may go on to do some further testing if this patient's having shortness of breath. Maybe it's a PE. Okay. A lot of false positives are common with D-dimers, so they're not super accurate as far as that. But different things like recent trauma or recent surgery, trauma, infection, heart attack, cancer, pregnancy, all of those things can cause a D-dimer to be falsely elevated. Do you notice a lot of risk factors in here for blood clots? Okay, so they kind of like go hand in hand. But if a patient has had recent surgery, there's really no point in running a D-dimer on them because it's probably going to come back positive. So if the physician has a high suspicion of a blood clot and the patient had surgery, they might as well just go get the lower extremity duplex, okay, to rule out a DVT. But let's say the patient has none of these and they don't really have a lot of risk factors, but they have a little bit of swelling in their leg. The physician may choose to run the D-dimer first because it's very inexpensive, okay, even more inexpensive than ultrasound. So they may choose to run that first. They can get results within typically a half hour. If it's negative, the patient goes home. Okay, if it's positive, then we go on to further testing and looking into it more. So some physicians choose to use this route with a D-dimer. Some choose to just, kind of go for the sure thing here with ultrasound. So it's really physician dependent and patient dependent, given what their circumstances are or if they have any other things like cancer, trauma, we know that's going to cause a false positive. I didn't put the specific numbers on here as far as, the lab values and what is positive versus what is negative. I don't think that's really important to memorize because you can just look in the patient's chart once it's ran to see where it falls as far as the level and just know. If the patient has a positive D-dimer, that is part of their history. You want to include that for the physician. So you would add that into your tech report. Okay, and lastly, just talking about our tech notes and what we're going to document and send over to the physician for reading. So we always want to document our patient history, no matter if those are symptoms that the patient has, what risk factors do they have, what in Virchow's triad do they have, so what risk factors, are they obese, are they on birth control, do they have cancer, any of those things you want to document. A positive D-dimer you want to document, okay? Then as far as the study itself and what you're going to document compressibility of vessels. Every single one you need to document whether it was compressible, partially compressible, or non-compressible. Okay, if it's normal, should be all compressible. Document patency. Did you see good color flow going through it, each vessel? Categorize your waveforms as far as, are they phasic? Are they spontaneous? Did they augment? And you're not going to augment for every location. So you're going to do that specific, to whatever the location is. You're going to document any incidental findings. Did you find a Baker's cyst? Okay, great. I'm going to write that I saw, a fluid collection behind the knee. It measures this and it didn't have blood flow. Okay, something simple like that. If a blood clot is found, okay, some of these things you're already going to say, the common femoral vein was non-compressible. It did not have flow. But then you want to go on to further define it as acute versus chronic. Okay, and you can do that as a technologist. You're going to say it has, acute symptoms because it was non-compressible, it was dilated, or you're going to say it was chronic because it was small and it was bright and, different things like that. So you're going to go on to further define this DVT as more acute or chronic. And as always, if you struggled at all during the exam, be sure to document it. maybe your patient was very large and it was limited due to their body habitus, or maybe just patient positioning. It's really key, especially when you get to the calf. You want your patient to have that leg flexed to the side. And if they aren't able to do that, it may limit your visualization of the vessels. So you always want to document kind of to cover your butt and make sure, you know, that you said, I really didn't see the perineals well, because what if there was a clot in there and, you know, you missed it? Well, if you didn't document that it was hard to visualize, then potentially, you know, it could come back on you that you missed it. So I look forward to working with you guys in the lab on this and getting you really comfortable. We are going to spend about 2 weeks on lower extremity venous. Like I said, it's one of the most common exams that we do. So I want to make sure that you're really comfortable with, you know, the protocol itself and scanning of this exam.